going to describe to you and demonstrate some of the techniques which have facilitated difficult intubation. First, laryngeal mask airway. Laryngeal mask airway was introduced by Dr. Brain in 1985. Prototypes were constructed from 10 millimeter endotracheal tube and black rubber cuffs from Goldman dental masks. This forms an effective seal around the larynx when suitably shaped and placed. The size, including the mask portion, is 8 by 4 centimeter and inflated. A special introducer which consists of a 2 millimeter strip shaped like a flat spoon having a hole at its center 2 by 3 centimeter functions like a stylet for this kind of laryngeal mask airway. It is placed on laryngeal side of this airway. The upper rim of the airway must lie against the epiglottis. Jet stylet endotracheal catheter is a catheter 65 centimeter length. It has 3 holes at the end. When it's connected to high-frequency jet ventilation, these 3 holes would prevent from tissue trauma. It has 3 marks, 20, 25, and 30 centimeter marks from the distal end. This is placed inside the trachea, similar to regular endotracheal tubes. Laryngoscopy is done. The catheter is placed inside the trachea. Then this can be attached to high-frequency jet ventilation. Patient can be ventilated with high-frequency jet ventilation, and after patient is ventilated, if it's needed, we can exchange this catheter with regular endotracheal tube. Then the catheter is removed and patient can be ventilated with either ambu bag or anesthesia machine. Urethral catheter can be used to facilitate intubation in neonates. The same catheter which is used for urethral can be bent at the tip by the wire which is inside. The bent would help to introduce the tube into the endotracheal tube by rotating from the top. Then fiber optic is done through the other nostril until it gets into the nasopharynx and you can see the glottis. Then the catheter is passed through the other nostril and the direct observation, the tip of the catheter is manipulated somehow to get into the trachea, and after the catheter is inside the trachea, endotracheal tube is passed through the nose and is passed into the trachea. Retrograde intubation or transtracheal guide for intubation. CVP catheter can be used for this purpose. CVP catheter, the needle which is at the end does fit with slip tip syringes. The lower lock syringes cannot be fitted here. After this needle is attached here, It is passed through cricothyroid membrane while aspirating is continued until air bubbles appear. Then we would know that the needle is inside the trachea. The catheter, which is still sterile, is passed through this needle until it comes out through the mouth. We'll pull it out through the mouth. Then endotracheal tube can be passed over this catheter. The other tip is held in hand. The tube is passed until it's close to the trachea. Then it should be rotated 90-degree counterclockwise, and after the tube is near the cricothyroid membrane, close to the entrance of the catheter, this catheter is removed from here, and the tube is advanced. Transtracheal jet ventilation. If patient cannot be intubated and cannot be ventilated by any means, this is a life-saving measure. Transtracheal injection is done, as previously explained. The tip of the catheter, it's nice to be punctured with little holes. It can be done under a sterile fashion with a glove and a 22 gauge needle. A few holes can be made at the tip of the catheter. This would prevent from tissue trauma when it's jetting. The catheter should be size 14. It is passed through cricothyroid membrane, and we keep aspirating until we see air bubbles. Then the catheter is left there. High frequency jet is connected, and patient can be ventilated with high frequency jet ventilation. While other measures or other treatments is done. If high frequency jet ventilation is not available in your hospital, a hand jet ventilation can be done by this method. Although there are some manufacturers that they have made one, but this can be made by yourself at your own place. A 2 cc syringe attached to this Y connector. A suction tubing is connected to this side, and the other end of the suction tubing can be connected to regular connector of endotracheal tubes. This side is attached to the fresh gas flow of the anesthesia machine, and tracheal puncture is done as it was explained before, and this 2 cc syringe can be easily connected here. An assistant should keep his hand over the oxygen flush, and by pushing your thumb over this hole, you are giving inspiration, releasing, giving expiration. And doing that 100 to 150 times per minute, you can very easily and adequately ventilate the patient until other measures can become available. Flexible fiber optic. Patient is prepared in usual manner as far as sedation is concerned, and he is sedated up to the point which patient is not having respiratory depression. The mouth is anesthetized. Decongestant is placed into the nose. Local anesthesia may be used in the nose. Transtracheal injection with local anesthetic can be done. Superior laryngeal nerve block can be performed. Then operator makes himself familiar with the fiber optic equipment. By moving this handle up and down, we can change the tip of the flexible fiber optic. The light source is checked. The operator's eye should be focused so he can see in very nice picture. Then the mouth should be kept open. We may do laryngoscopy, and assistant may hold the laryngoscope, or after laryngoscopy we may put this mouth gag in the mouth and laryngoscope be removed, or use this kind of mouth gag between the teeth. And the tracheal tube may be passed over the fiber optic. Operator will look through the fiber optic until he sees the glottic, and the fiber optic is passed between the vocal cords, and after the fiber optic is inside the trachea, the endotracheal tube is passed over the fiber optic and should be rotated 90-degree angle counterclockwise toward the left, and the tracheal tube is passed into the trachea and fiber optic is removed. Aids to fiber optic intubation. There is a special mask for this purpose. This mask has a hole with a plastic rubber covering, and this would allow the passage of fiber optic and passage of endotracheal tube through it. Mask anesthesia is started and is continued up to deep levels of anesthesia. Then fiber optic can be performed while the patient is fully anesthetized. The fiber optic is passed through this hole, and while an anesthetist is giving anesthesia, the person who is going to do the fiber optics is passing this fiber optic through this hole until he sees the glottic and passes the fiber optic through the glottic, and the tracheal tube also can be passed through this hole. And when the fiber optic is, while the fiber optic is still inside the trachea, the tube is passed through it, and this tube can pass through the mask also and can be taken out through here. Connector is attached here, and ventilation can be continued. Transtracheal puncture can be done, and then a long angiography catheter, 260 centimeters, is passed through this. When the wire comes to the mouth, we'll pull it out by either fingers or by McGill forceps, and then it is passed through the suction port of the fiber optic until the other end comes out through the other port. When it comes out through the other side of the fiber optic, that can be pulled from the two sides, and fiber optic can be guided toward the trachea, and trachea and glottic can be found much easier and quicker, and then the rest of the procedure is done as before. Another aid to fiber optic intubation is to insert a nasal airway through one nostril attached to anesthesia machine, and anesthesia can be established while spontaneous breathing is continued, or it can be assisted by keeping the mouth closed and assisted ventilation. And in the tracheal tube, we can occlude it by a diaphragm This diaphragm is taken from connectors of double lumen tube. We can put this diaphragm here, keep it fixed here. We can put a piece of tape to secure it, or attach it directly to connectors of endotracheal tube. While patient is anesthetized, fiber optic teaching and action can be continued, and patient can be intubated this way. High frequency jet ventilation in massive bronchial bleeding. One of the severe complications of Swan-Ganz catheter is bronchial bleeding. If that occurs, that can be fatal. One treatment which has been done is to establish high frequency jet ventilation, doing the laryngoscopy, putting jet stylet tubing connected to high frequency jet ventilation, and while ventilation is continued, suctioning through the trachea and the mouth can be established. This has been shown, which provides adequate oxygenation and anesthesia. Another problem that you might be faced with, if a patient has a big chest or the neck is flexed in a fixed position, then regular laryngoscope, the handle would be on your way, and you just can't do laryngoscopy. There is adjustable laryngoscope. That angle can be changed any position you want to, and then fixed. This way, laryngoscope handle would not be on your way. A few words about loose teeth and broken teeth. If a tooth is loose, what we can do to prevent from aspirating of that tooth, we can get a suture and roll it like this, bring it to the tooth, and then tightening it here, and then we can put the tape here, so if the tooth is broken, it will not go down into the hypopharynx and trachea. If multiple teeth are broken, we can protect those by putting this mouth gag inside the mouth, protecting the teeth before laryngoscopy is installed. If this one is not adequate, we can do what the dentists they use. They mix with a powder, and they get a cup of water and have this measure exactly. Fill it up, mix it, they wait 30 seconds, when it starts getting hard, then we put it on this and put it in the mouth, wait another 60 seconds, and after 60 seconds this is hard enough to be special mold for the teeth. What can we do if we cannot ventilate, if we cannot intubate the patient? There are some other equipments available. This is called esophageal obturator. This has a blunt end, and if you hold here, this blunt end would prevent from regurgitation. This is placed inside esophagus, and then mask can be connected here, and patient can be ventilated by ambu bag or by anesthesia machine. If this is not available or possible, then the last choice may be doing a quick tracheostomy. This can be done by attaching a syringe to this new trach. Trachea can be punctured until aspiration is seen. That means the tip of this needle is inside the trachea. Then we can take this off. The needle is removed, putting a tracheostomy tube inside, and after the tracheostomy tube is inside, this knob can be turned counterclockwise. This one can be removed. The rear one can be removed, and tracheostomy tube be fixed there by tying a rope around the neck and keep it fixed here. And then ventilation can be continued. If you have high-frequency jet ventilation in your hospital available, one other technique which would save you from the risks of tracheostomy is to pass an angiocat number 14 through cricothyroid membrane, and you pass it until you see air bubbles. Then you connect it to high-frequency jet ventilation. Another aid to the teaching and practice of fiber optic intubation is to establish and continue transtracheal jet ventilation under intravenous anesthesia, and then do fiber optic intubation. This concludes all different techniques which facilitates difficult intubation. At the end, I gave you a few techniques. If you cannot intubate by any means, what we can do and how we can prevent death. By doing these last few techniques, you can continue ventilation of a patient until he is in a proper shape and proper situation.